Welcome to Life in Sirens, Behind and on the Scene, a podcast by first responders. We're your hosts, Sophie,
Jaime,
and Aubrey.
The content provided in this podcast is for informational and educational purposes only and should not be considered medical advice. The views and opinions expressed by the hosts and guests are their own and do not necessarily reflect the official policies or positions of any medical institutions, emergency medical services, or healthcare organizations. Patient privacy is a top priority, and all discussions involving real-world emergency situations are de-identified and altered to ensure confidentiality. Always consult with a qualified healthcare professional or your local EMS protocols before making any decisions regarding patient care or medical practices. Listener discretion is advised, as some topics may include discussions of real-world emergency situations.
EMS is mostly shades of gray. Today we're breaking down the moments where you have to make safe decisions with limited information and trust yourself and your partner.
Welcome back to another episode of Life in Sirens. Today it is me, Soph, and Aubs. We are all back together again. And what we're talking about today is what would you do if?
Dun, dun,
Oh yeah, this episode is all about the scenes where medical knowledge meet the real world chaos and how plenty of perspectives, 3, like ours, might make you think a little differently. So we're going to go through some scenarios and talk about what we might do in these specific situations. What we say or do is not reflective of any agency or organization. This is just for fun. So
For
take a deep
funsies.
breath.
Yeah, for
Nobody
funsies.
report us to ACLS, AHA, any of the...
Yeah, we don't
People.
know her.
It's not that serious.
We don't know her. All right, so let's get into segment number 1. Like Soph said, this is going to be a clinical decision-making scenario. You're dispatched to a fall. No further information is given. You arrive to find a middle-aged male sitting on the ground. Pale, cool, diaphoretic, classic. You get vitals. You find his heart rate is 138. Blood pressure is 88/54. Respirations are 24 and shallow.
Oof.
Man, that shock index ain't good.
It is not good. He's awake but slightly confused, repeating himself and struggling to explain what happened. Bystander number 1 says he fell off the porch. Bystander number 2 swears he was assaulted.
He was assaulted, bro.
Bystander number 3 insists he just collapsed.
Interesting.
None of the stories match. There's no obvious external bleeding, and the patient's presentation suggests early shock. I don't know how early we are in shock.
Full-blown shock.
Yes. Suggest early shock with a potentially significant underlying mechanism that you don't fully understand.
It is a bamboozling event.
It is.
You're getting bamboozled. You are now faced with a key decision. Do you perform a short, targeted on-scene stabilization, airway check, bleeding control, quick exam, packaging? Or do you immediately prioritize rapid transport to a definitive trauma care? This is the moment where you have to decide what's safe to do on scene. Is this scene safe? And what needs to wait until you're moving toward the hospital?
Yeah, what the heck is going on this scene? Is it safe? I have no
Right?
idea.
These bystanders are sketch.
You're sketch, for sure.
I do not like that. He fell off the porch. He was assaulted. He just fell down.
Okay, so one of you is telling the truth, and 2 of you are lying.
Right? Listen, I'm going to go with bystand number 2 is definitely telling the truth.
Absolutely.
Yeah, I'm going to go with the one that's the most risque.
Yeah. He was definitely saltied.
Yeah. I think assume worst case scenario,
Mhm.
especially
For
for
sure.
your safety.
Correct.
But to be perfectly fair, I do think you still perform a short targeted on-scene stabilization.
Yeah. And it also may depend, like, how sketchy this is, right?
Yeah.
There's so many things. That's
Right.
why we made these really vague.
Yeah.
Right?
Like, are they currently trying to shank you?
right.
Or are they all
Are
standing
they all
around?
screaming at you?
Right? Are they all just standing around looking at each other?
Yeah, are they
'Cause-
pointing fingers at each other?
Yeah.
Spider-Man guns.
Right? Like, we've collapsed. Do we need to just, like, start bagging, throw on a
Yeah.
C-collar,
Is
make sure we're not
Did
hemorrhaging?
he collapse, right? Did he have, like, a cardiac event and then fall off the porch?
Right?
Is this guy who's saying that he got assaulted just, like, super paranoid and hates the neighbors?
This
like,
could be everybody's PTSD presenting.
right?
Everybody is
For
reliving the
sure.
worst thing that they've ever witnessed, and it's manifesting in this man.
Absolutely. This
true.
could just be like a delusional disaster. However, I do think that you quickly manage your patient,
Yeah.
like bag them,
ABCs.
collar, make sure we're not hemorrhaging from somewhere, get ourselves in the truck, and then we can adjust from there. Because I think that initially, like, determining definitive care, you got to at least figure out what's going on first.
Yeah, and I think that obviously we do need to go to definitive care, and we didn't put in here like how close we are proximity-wise to like a trauma center. So I think this could be one of those situations where you do get to the truck, stabilize, and maybe we decide if we need air, and we drive to them.
Yes, get ourselves off the scene, meet them at a predetermined LZ. Sounds like that's probably a good.
Yeah, get
a
the
good
heck out of
move.
there.
Yeah, I think what sticks out to me the most just immediately is that this is a scene that you know nothing about, and it doesn't sound like you're going to get to the bottom of it anytime soon. And the place that you can control the most is the four walls of your ambulance. So do what you need to do to get this patient to a movable position, move him to the truck, and then figure out your next move.
And then consider all things, right? Like maybe they did have a medical emergency. Like let's, I guess, work this up like medical and trauma.
Yeah.
This
We
could
don't know.
be. Yeah, this could be a medical turn trauma.
Yeah.
Put on your Sherlock Holmes hat and figure some
Absolutely.
things out.
I also think it's important to mention that you're an advocate for your patient in multiple ways. So remember that, like, if you think something's sketchy, if you think bystanders are sketchy, first, get yourself and your patient safe. But second, notify law enforcement if they're not already en route.
Yeah.
Make sure that if your patient does have a negative outcome, that they have every chance for this to be handled appropriately as they can. So remember that you're not just their medical advocate, but you're also kind of like their like ethical advocate as well.
Yeah,
I
absolutely.
think this scene really highlights that like there are so many things that we have to sort through in like just moments. We don't know their whole life stories. Bystander 2 that swears he was assaulted could be like, I don't know, an in-law, and she just hates bystander number 2 and or number 1 and 3 and is just like convinced that they're out for like they just
Absolutely.
they want all the money. They're trying to get rid of him. You know what I
Absolutely.
mean? Like we do not know their whole life story. There could be so many things happening here.
So much. And you literally, all the things that we're talking about happen in the first 30 seconds that you get there.
Yeah. And
You
I
got to
bet-
suss everybody out so quick.
What in the Murdaugh is happening here?
I mean,
Man.
something, you know?
That's a can of
And
worms.
honestly, maybe we were like, maybe bystander 2 is right. He was assaulted. But if you look at bystander 1 and bystander 3's stories, he fell off the porch and he collapsed and fell off the porch.
Those could be
All
the
are
same.
true. All of the above.
Yeah.
Or was he whapped in the head with a hammer, which caused him to collapse and fall off the porch?
Exactly.
That's what I'm saying. All of the above.
All the
It's
above,
all
man.
true.
It's
He
all
fell
true.
off the porch, guys. Let's figure
Mhm.
out what's wrong with his insides.
Yes.
And on a practical note, if you have a bunch of bystanders telling you different things and your patient is clearly unresponsive, go with the worst possible case scenario. Err on the side
they
of
had
caution.
a stimmy and fell off the porch and got
Yes.
injured.
Yes, and then also got whapped with a hammer.
Yeah.
Like, err on the side of caution and start from the tippy top of what could be the worst possible case scenario and then work your way down.
Exactly. Rule out the life threats that you can reverse, or, you know, obviously, maybe we need to go real fast. Maybe he's not that injured inside, and maybe it is a medical problem,
Yeah,
but maybe he still needs the aircraft.
absolutely.
That's
I think
just-
that scenario number 1 is stabilize and escape.
Yes, I think that is the point, is don't get lost in the weeds of how did this happen?
Mm-hmm.
Because sometimes you're just never going to know.
And that's why you called a popo.
Yes. So call for help, additional resources. Identify if you need air medical, which is part of your additional resources. And yeah, make sure that we are doing best for our patient, even if that means we have to go to a closer facility first and stabilize. I think that we miss that a lot. I feel like we miss that a lot.
Absolutely.
And it's okay to do. It sucks. It shouldn't be your cop out, but just know where your resources are and
Absolutely.
where you might have to stop.
Sometimes you need things that you don't carry, and sometimes air is not an
Blood.
option. So if it's something like you don't have blood, they have blood, or you don't have RSI capabilities, they do. Sometimes, like, it's a tornado outside,
Yeah.
and so you've got to go to your closest facility.
Mm-hmm. Let's jump into scenario number 2. You arrive on scene to find a patient in severe respiratory distress, altered, barely maintaining their airway. Respirations are agonal and irregular. Oh yeah, they're not maintaining their airway at all.
Mm-mm.
Airway failure is coming fast. Your partner immediately
is failure.
says,
Airway
"We are
failure
there,
has already
actually.
happened.
You passed it in the rear view." Your partner immediately says, "We need to RSI now."
Right now.
Your supervisor, who has also just arrived, disagrees and says, "Bag them and go. We don't have time for an RSI on scene."
Tick-tock, tick-tock.
You're in a
Dilemma.
small living room with limited
It's
space.
almost like
Family is watching, panicked, asking if their loved one is dying.
Yes.
The patient is declining by the second. Every option has consequences. Every second matters. You need to decide. Do you attempt an RSI on scene and risk delaying transport? Or do you provide BVM support, secure what you can, and initiate rapid transport to definitive care? This is your split-second judgment call.
I like to point this out, and that's why we created this scenario, because it is quite a dilemma. But your supervisor is not your medical direction. So they
Yeah.
can't just tell you not to do something that's appropriate. I do want to start there.
Absolutely. I love that. Also, both. My answer is both.
Yeah.
You need to be swift, but you need to be appropriate. So someone with a agonal and irregular respiratory pattern, that is a failed airway. That is a respiratory failure, and you need to manage it. And managing it when you are an ALS provider is not with a BVM.
Yeah. And let me give you their vitals. So I would say this person's peri-arrest because these are their vitals.
What a great-
Heart rate. Oh.
I'm already agreeing just based on...
She said, I know what they are.
I mean, they are. They're agonal respirations,
Yeah.
right? They are circling the drain. Their
Dang.
heart rate is 136.
Mhm.
Their
Good.
blood pressure is 70/40.
Even worse.
Yes. Their blood sugar, they haven't gotten that yet.
Not important.
And what else do I need? Oh, their SpO2 is 72 and their end tidal is 68.
Oh, no.
We're doing so well.
Okay.
So like there's a lot we got to
Yeah.
do, guys.
Somebody check
We
for
are peri
Ross.
arrest. So
Yeah.
step
But I'm saying like this patient does not need, if you load and go this type of patient, I
Mhm.
would anticipate that they are going to code during that process.
Absolutely.
Correct.
And in the same vein, if you just immediately RSI this
They're
patient,
also going
they
to
are
go.
going to arrest.
Yes.
So everybody's
So-
wrong and everybody's right.
Yeah. So what do we do, guys?
We do what I like to call ABC 123.
Ooh.
This is my mantra that I say in my head when I'm when I'm panicking.
I love it.
I say ABC 123 because you learn in school, you go to A, you go to B, you go to C, right? You don't stop, you don't go to B until you finish A. When in reality that is not true.
Yeah.
A,
Simultaneous.
yes, it all happens at the same time, but it's ABC 123 because you have to do it at least 3 times, right? Your first step here is you're going to get out of BVM and you're going to start ventilating. That takes care of A and B. And to be able to RSI, you then have to work on C, right? We have to get access, we have to get fluids, we're probably going to get a pressor going, like all of those things. Once you finish that C, you're going back to A because now we're working on a definitive airway and all of those things. So this is a classic ABC 123.
That's
I like
beautiful.
it. I like it. That
I love
was
that.
beautiful.
Thank you.
Yeah. So I think depending on what our cause of this peri-arrest is, sounds like
Yeah.
it's going to be a respiratory failure.
Yeah, that
Yeah.
end title was wild.
Yes,
Yeah.
we need to get some hemodynamic stability on board. So we need to start thinking about pressors. We need to start thinking about fluid. We need to see if we can figure out the etiology of our failure.
Yeah.
You know, we
Absolutely.
need to start going down all those roads. And then we can consider RSI and
Oh.
choose your meds appropriately.
Let me add this, okay?
Ooh.
She's very difficult to ventilate.
Oh. Oh, jeez.
Like,
Maybe she was sitting at the dinner table.
Oh, dang. She's a
and
choky
her sister
choky.
came over and was like, found her on the floor.
Great. So we're going to get in that
Oh.
airway with some McGill forceps and see what we can find.
You find something.
What do you find?
You
like
find a
in
chunk
there?
of steak.
no.
It's always,
Man, it's always steak.
it always is a steak.
It's always meats.
Mm-hmm.
All right, we'll get that thing out of there.
Yeah.
Yeah.
This is like best case scenario.
Yeah,
really.
this is like you get
Yeah.
that out, start ventilating her. Maybe she just like pops on up.
Well, she doesn't.
Okay. well,
Oh.
Dang, that steak really got her.
It's
did.
kind of
It's
fun.
in there.
Oh, man.
So
All
just
right.
has the puppet strings.
Yeah.
Yep, steak's out.
All
We're
right.
ventilating better. Yeah.
She's ventilating, but
Is this
her-
what you call a high stakes situation?
Oh, damn it.
I had to. I'm sorry.
I'm glad you did. It is high stakes, absolutely. But you're rolling with it. You're doing
Yeah.
a great job.
Okay.
So you removed the airway obstruction.
Great.
She is bagging more easily.
Thank God.
but it looks like maybe we aspirated or something. It's kind of funky in
Yeah.
there.
Sounds about right.
Hmm.
So I still think RSI is going to be our end goal.
Yeah, I think that is an appropriate end goal. But what do we do to get to the RSI? And what do we do to make sure our supervisor is on the same page? Because
I was just about to circle back to that.
yeah.
Okay, I'm going to answer the supervisor question first because I feel like you got to get them on board before you
Yes.
can proceed with the rest. I think that you call out, you kind of do a timeout and you say, this is what we have. This is what our problems are. This is what I foresee happening in the near next to 5-minute future, which I cannot get to the hospital before that happens. This is my plan to combat that. I think 9 times out of 10 that will kind of dissuade whatever pushback you're getting. But also, I urge you to, if you are the one that's not on board, or maybe you can even say this to help get them on board, just remember that if you are confident in the skill that you are about to do, you are not wasting time, you are borrowing time. You're just swapping time with the ER, because as soon as you present to the ER, this is the step they are going to take. So, all of the time that you are spending driving to the ER for them to then do that intervention,
It's just
when you
delaying
could have
care.
done it on the front end, you were just swapping time. You're not wasting time.
The first time you ever said that to me, I was like,
Yeah.
I had an epiphany
I was about to say the same words.
Mhm.
Epiphany.
because it was wonderful. You said, like, Jane, we're not delaying care. We're just swapping the time that it happens in. And I love that.
I would argue that this would be delaying care.
Yeah,
Yeah.
I would too.
And I also think that with supervisors, you have to remember that a lot of times what they're worried about is optics, right? Because you're in a different role then.
Yeah.
You're managing scene, you're managing other responders, you're making sure that everything is going smoothly and appears to be going smoothly, right? Like they're there to protect you, ideally. So most of the time with supervisors, if you can just basically tell them like, hey, I have a plan. This is my plan and this is why it's a good idea. Most of the time, like they're down.
Yeah, they're
It's
just
just if they
another
get-
human.
Yes,
It's
like
hard to say no to reason.
it is.
Correct.
And a lot of time it's just if they get there and it seems like you don't have a plan, then they're like, bag them and get out of here.
Yeah.
But if you can articulate a plan and you can articulate it well, most of the time they're on board.
Let's play devil's advocate here because we're lucky to have supportive supervisors. What if you're working somewhere where they don't and they're like, no?
What's their licensure?
who do you call?
level? Medical.
Ghostbusters.
You can call medical director Ghostbusters.
Basically, yes.
Medical direction.
I would
Mhm.
venture to say that it would be appropriate to call medical direction if they are just being just ridiculous. I would
unreasonable.
say that's a very low case, but if they are,
Mhm.
because I've been in situations where it is a little more difficult to like come to, not necessarily we're like out for each other, but to come to an agreement of what to do next.
Yeah.
I
I also think that
think that's appropriate.
yes, and I also think remember like stand your ground.
Yeah.
Like if you are
You're a
doing
patient advocate.
yes, if you are doing what is the most appropriate thing for your patient, stand your ground. EMS is different than other first responder agencies because our hierarchy is not only about rank. Our hierarchy also has to do with licensure. And so although we respect our rank and we
Yeah.
respect our leadership, you also have to remember that rank may be the exact same licensure as you.
And you're the transporting medic.
Yes. So if you end up in court and you say, well, my supervisor at the time told me that I should just start driving, and they say, well, what's their license level? And it's the same as yours or lower than yours.
Yeah.
You have to remember that license level matters in EMS. And so as long as you are doing what is correct for your patient, if you have to stand your ground and maybe puff out your chest a little bit, do so.
Yeah.
Because
so
it will
we
save
will
your
support you.
license and hopefully their life. So
Yeah.
Yeah.
And I think that's important at the end of the day. And again, like, worst case scenario, you have to, and I venture to say, if you look at that supervisor and say, well, I'm calling medical control, they're going to be like, okay, fine.
yes.
Say
Yeah.
that you won't get that far.
Yes. Because I think rarely is it malicious.
No,
Most of the
no,
time it is
no, I
either
don't think so.
fearful
Or
it
ego.
is, yeah. It is either fearful, it is ego pride, or it is optics. And most of the time you can kind of negate that
Yeah.
by 1, explaining yourself, 2, make it their idea.
Yeah. That's like number one. And like, we need to have another episode on
Yes.
how to function in a way that is diplomatic but effective.
Yes.
Yeah.
A huge part of diplomacy in EMS is, man, as much as I hate to say it, is like kind of appealing to another medic's ego if they are becoming an issue for you on scene.
Well, most issues arise out of ego, so
Mhm.
I would say that's a very important skill,
Yes.
especially as a woman in this field.
Yes, to be able to be like, I know that you would do this. Do you think I should do this? And they'll be like, yeah, yeah, yeah.
Yeah, I would totally do that.
Yeah, yeah, yeah.
So to recap, we've removed our airway obstruction. We are ventilating. How are we going to get our pressure up? What do you guys want to do?
I want to do a fluid bolus.
All right.
I think that's responsible. Make sure our tank has some volume in it. And then I would like to do a pressure.
All right. I think that because your fluid bolus, it got the pressure up to 72.
Oh, so nice.
Oh,
It said,
bring out the big guns.
Yeah.
Is it?
blow in
Exactly.
the wind. Yes, and then a pressor for sure.
So our heart rate is 138 and our blood pressure now is 72/48. What pressor would you like to use?
Probably Levo.
I think so.
Yeah.
We love her.
Yes.
Yeah.
She for everybody.
All right. You have given the fluid bolus. You have a line established, obviously, because you're giving Levo.
Oh, yeah.
You are ventilating still with a BVM and an airway adjunct. Your pressure now is 102/70, and your heart rate is 99.
Oh, what's happening there? Oh no.
Have you checked anything else?
Oh, is this medic school rules? Can I get a blood sugar? Can I get a 12 lead?
I'm actually just messing
Can I
with
do a
you.
head-to-toe assessment?
This is just fun for me. She's fine. Her
thank
oxygen
God.
is 92%. Her end tidal is coming down. It's in the 50s now.
Okay. I like
Okay.
that. Is her mentation improving at all?
No.
Still like GCS3?
Yeah.
Okay.
All right. Do we have a
Oh.
gag reflex?
We have an OPA in.
Oh.
It's a good catch.
Interesting. So this is an interesting ethical question that I have run into multiple times, is that if your patient doesn't have a gag reflex and they are hemodynamically stable like she is, but I would say on the fence, do you RSI or do you just intubate them? Because we don't actually know where her mentation is. So we want to
Yeah.
make sure that we are not like torturing people, right? So you could absolutely intubate like that. However, if you are RSI capable and you are maintaining their hemodynamic stability, I think that it is the most ethical and responsible to go ahead and RSI them.
Yeah,
Would you agree?
I think so. I think it's also safer for our patient if we have the opportunity not to deviate and it's not going to negatively impact them from like our normal checklist and how we RSI someone, because we already made the decision that we need to RSI, so we think they need it. So you might as well just pull out all the stops. For me, that's how I would do it.
I also, at this point, we are not compensating. Our airway is clearly compromised. We've been agonal. The removal of the obstruction has not improved any of our effort. Now, now I want to take over this for you.
Mhm.
Like, I do not
She
want...
needs to rest.
Yes, I do not want your body to start trying to, like, buck the tube and try to take, like, these intermittent respirations. Like, for at least the next 30 minutes, I want to be in full control
Yeah,
of this scenario.
absolutely. Especially once we like have the opportunity, depending on your setting, if you do have like a vent or whatever it is, like to make them more comfortable. But I would say 9 times out of 10 in our situation, you will not have a ventilator, and like even if you don't have PEEP applied, you're delivering a lot of pressure, which is uncomfortable.
Mhm.
So if we can just chill them out, I think, as much as possible.
Yeah, get the
It's
most amount
helpful.
of compliance
Yes.
with the least amount of consciousness, I
Yeah.
think is probably
Yeah.
the best, yeah.
These are patients that need rest, for sure. All right, now what? You RSI'd them.
All right, great. We're going to make sure that end title is good.
The end tidal is, your waveform is good. Your end tidal is 52.
Okay. I'll take
Blood
it.
pressure.
Blood pressure.
Blood pressure is 98
Okay, great.
systolic.
Great. What's our Levo running at?
What did you start it at?
I started it at 12.
Nobody's changed it. Their map is 64.
Great. We're going to leave it at 12.
All right.
If we need to, depending on your protocol, you may have to call for medical direction to go higher than 12 mics a minute. It depends. Some people don't. Some people have much more of a leeway there. But if you do, call your medical direction.
Yeah, I think that's reasonable. She's, and that pressure very well may continue to go up. Are you still, well, now that we're like chilling out, right?
Yeah.
Her body's starting to rest.
For
But
sure.
keep
And
an eye on it.
Yes, keep an eye on it, but don't
Get
be
another line.
don't be super alarmed after you RSI and intubate and you've been ventilating for a minute, if the pressure does start to come down a little bit, because now like we're relaxed, our body is starting to chill. So keep an eye on it, be responsible with your pressor, but don't like immediately panic and dump 20 mics
And she's
a
a little
minute.
granny.
Yeah. We're just a little bit more.
So we're ready for transport decisions.
Yeah, buddy.
It's raining.
Of course.
And you are 40 miles from a general hospital with an ICU, and you are 60 miles from a comprehensive level 1. They have all the things.
All the things. I think level 1 is going to be our answer.
You already did all the things, right?
You already did all the things. I think that your considerations are, do you have the appropriate amount of oxygen to make that transport?
Mm-hmm.
If not, is there an intercept opportunity? Is there an opportunity to obtain a vent? Because that will be safer for your patient. And if the answer to any of those questions is questionable, then go to your closest facility.
They have an ICU, right?
Mm-hmm. And then they can transfer, or you can transfer, whatever you got to do.
I agree. I think that if you have a ventilator, it is more than appropriate to go the extra 20 miles, as long as your patient remains stable. But if you needed to divert to that 40 miles away facility, I think that's reasonable.
All right, so scenario number 4. All right, so you were dispatched to a possible fall with head injury outside of a local bar. On arrival, you find a highly intoxicated adult with a visible contusion on the forehead. They're stumbling, slurring, and insisting that they don't need a hospital and just want to go home. Their friends say they hit their head on the sidewalk. They refuse vitals and keep trying to walk away. Police are already on scene and growing impatient. One officer says, just take them, they're drunk. Another says, it's jail or hospital, your choice. They're pressuring you to make a decision. The patient keeps repeating they don't want treatment or transport. You now have to determine whether this patient has the capacity to refuse care despite intoxication, a head injury, and conflicting demands from law enforcement. This is a high-risk situation where you must decide if the patient truly understands their condition and the consequences of refusal, or if their impairment makes them unable to make an informed decision. What do we do?
First thing, I'm calling for a supervisor to be an additional witness for me. I need somebody to be here with me.
Mm-hmm.
We need to talk to the friend. It seems like they saw everything happen. If this patient is not going to immediately talk to us or allow us to approach him.
Right. Even if you, depending on the size of the bar, even if you talk to like the bartender, how much did you serve them? Is this level of intoxication appropriate for how much they drank?
Yeah.
Right? Like if they're like, they just got here, they had one beer and they're stumbling around like.
And they were fine when they walked in. Yeah.
Yes. Like they've had like a fifth of vodka. You're like, oh my God. Like then our propensity for a head injury is far higher.
Yeah.
If their intoxication level meets their intake level, like reasonably, I think that you have a little bit more time to maybe try to like reason with this patient and talk with them and try to figure out their capacity level.
I think that in this case too, like it could be a situation because if this person is intoxicated, that could make them a little more fearful of the police and what they're, especially if these guys are like, just take him to jail. I don't know either, so they really want him to go to jail. I don't know what he did, but it could be maybe prudent to separate him from PD and allow him to like talk to you freely and inform him that we are just here for his injuries.
And a lot of times we all wear like Navy, and especially if you're drunk people do not recognize that you are different than the police. And so even to just like clarify, like, hey man, like I'm not here to get you in trouble. I'm here to help you.
I'm worried about you.
I'm worried about you. Also, like I can get you away from these guys.
Yes.
You know,
I love that one.
Sometimes that works. Move, also, like, can drunk people refuse?
It depends.
It depends.
Someone call Sam.
Right? Yeah, so with intoxicated patients, they still have a right to refuse if they can, like, basically show capacity.
Right.
So just because you're intoxicated does not mean...
Some people are drunk all the time.
Yeah, does not mean you can't make your own medical decisions. But you do have to be able to support that you were able to prove that they have capacity to make those decisions. And so a lot of that is not just your, like, baseline A&O times 4 questions. Like, drunk people can pretty much get their way through that. But you want to make sure they understand the event. You want to make sure they remember the fall. They know exactly what happened, where they are, what's going on. Like, you want to really be able to justify that this patient was fully there with you and they understood the consequences of the refusal. Because if they cannot understand the consequences, they cannot refuse.
So they have to be able to talk to you.
Yeah.
How do you get them to talk to you?
I just get real pesky.
Real pesky. I think right off the bat, if you have a law enforcement agency that is trying to put pressure on you and or your patient to make a decision quickly, I think you need to, yes, I think you need to immediately take a minute and frame this in your mind as they have nothing to do with this medical decision. This is between you and your patient. And also, if this is going to be a refusal process, just remember, this is the one call that can take as long as you want it to. This is the one call you do not have a time restraint on. You can sit here with this patient and have this conversation for as long as you need to.
And if anyone tells you otherwise, get out of here.
Yes.
Yes,
this is not a call that you need to make a split-second decision on. Take your time.
Yes.
You have all the time.
And especially if you're concerned that this patient actually may have a head injury, you truly want to take your time and to talk to them and try to get them to reason with you. Now, let's say they won't talk to you at all. That gets a little questionable.
That's hard.
Because if your patient won't speak to you, it's hard to show that they have capacity. Now, we are not necessarily in the game of like chasing people down and bullying them into medical care. But I think that the key there is that you make a reasonable effort to care for this patient. If they are running down the street.
Hopefully they're detained if PD is trying to arrest them.
Yes. And so you make a reasonable effort. You talk to your patient. You let them know why it's important for them to talk to you. And most people, not all, but most people are pretty reasonable. I will say that if law enforcement is not open to you being like, hey, man, like, let me talk to them, a lot of times we will split them with partners. So one partner will take law enforcement and we'll go and talk to them and be like, hey, guys, I'm really concerned that they might have a head injury. And rarely is law enforcement like, nuh-uh.
Yeah.
You know, most of the time
Can
they're
you
like,
all get out of here? Can you turn your lights off?
Yeah, most of the time they're like, oh, really? And so if one of your providers takes a minute to go explain to law enforcement why you're concerned and you're not wanting them to just go straight to jail, like you actually want to provide medical care, and the partner stays with the patient, a lot of times that kind of helps you get further with both parties.
Well, and from a CYA standpoint, now that you've talked to this law enforcement officer and voiced your concern for this patient, there's a high probability that that is on body cam.
Mm-hmm.
So that's helpful. And I'm not saying just operate in a paranoid fashion, but that is good. That is important.
Yeah.
I will say, what if we deviate from this and the patient wants EMS and law enforcement is saying no?
Oh.
You know, honestly, that has happened plenty of times. It is a pretty easy thing to overcome if you just look at them and you say,
do you want them to die?
You are impeding medical care.
Yes, you're impeding medical treatment at this time. And everything is recorded. It's all body cam. At the very least,
that's where they're just mouth open.
Yes, at the very least, these departments have dash cams or recordings or, whatever it is.
Yeah.
And rarely, especially in today's climate, is a law enforcement officer going to look at you and be like, no.
I sure hope not.
Yeah.
Yeah, I think that we're in a place now where most officers are like, oh, please, I don't want to go to jail.
Yeah.
So I think you should be good. But if you do encounter that, be very explicit.
Yes.
You are
this
impeding
is
medical
serious.
care. Mm-hmm.
Yeah.
Now, what if we take it up from another angle and say that the patient does allow us to assess him, and we find that there are concerning findings on assessment, but he's still refusing. But he's alert and oriented, but his blood pressure is 270 over 110. His heart rate is 60, and that's all he will let us get. But he let us do those two things, and he does have a contusion to the back of his head.
But we are appearing to have capacity at this time.
He's answering all the questions that you ask him appropriately.
Ask more questions. I would say ask more questions, more thorough questions.
Yeah.
Try to explain the patient the concerning position they are in. I will say at the end of the day, again, make a valid, reasonable effort.
This is actually a call I went on.
Yes. But at the end of the day, people are allowed to make bad decisions.
Yeah. He already has made
I
some.
think you have a couple options here, because if this person is in custody, you then can go to PD and be like, hey, these are my concerns. He needs to be assessed at an ER before he goes to jail. And you kind of have that option, because then that kind of takes away the rights of the patient because he's in PD custody,
Yeah.
right?
That is a really nifty loophole.
Yeah.
Yeah.
Mhm.
Or you
Medical
always
control.
have medical control. Yeah.
Aubrey and I actually went on a call, and the patient was hypotensive, and they were alert and oriented, but every time that they would stand up, they would have a syncopal episode, like out
Immediately.
cold.
Oh, I
Yeah.
remember
okay?
this one.
And he was like bradycardic, I think. He
Mhm.
ended up being very sick, but he was so alert and oriented. We called our supervisor, and they were like, we don't know what to do.
Yeah.
So we called medical control, and they were like, because of his blood pressure, I cannot determine that he is adequately perfusing his brain,
Yep.
so you have to take him in.
Mhm.
So we had to call law enforcement. But it was the right decision because that patient ended up being very, very sick, as we suspected.
Yes.
But,
Yeah.
like, I mean, a doctor can say that. We can't, so.
Yes. And sometimes patients can appear very competent,
Yeah.
but are still making decisions they would not rationally normally
Yeah.
make.
I don't think that he called for help, right?
Yeah.
He's the one who called us.
Yeah.
So,
Yeah.
like, why all of a sudden do we not want to go?
Right. And I think that people get really caught up in two directions. It's either one, everybody can refuse all the time. We can't force anybody to do anything. And I took that stance for a really long time.
Yeah.
And then the other is nobody can refuse, snatch them all. And both of which are bad ideas. You need to make a valiant effort in each scenario to make sure the patient understands absolutely every possible risk. And stay put. Be pesky. If you really think this person needs to
We're
go,
pesky.
yeah, if you really think this person needs to go, stand your ground. Be
Yeah.
pesky. Be like, listen, darling, I can sit with you all day. Like, you
Right.
just,
And a lot of the times we've had it. This one was was not like anything we've ever encountered. But like sometimes if you just say, "Well, I'm gonna have to call the doctor,"
Mm-hmm.
they'll be like, "Okay,
Yeah.
fine,
Yeah.
I'll go."
oh, yeah.
I ain't getting past this.
Yeah.
Right. And the power of the white shirt.
Yeah.
They show up on scene, say the exact same
That
thing.
is
you
literally
said.
like just call a supervisor sometimes.
Mhm.
Mhm.
They'll show up and be like, listen, buddy, you gotta go. And they're like, well, I guess if you're twisting my arm. And you're
Yeah.
like, what? I've
I
been here for
literally
1 hour.
Said
been
that
here-
exact sentence 20 times.
Yes, 100%. Call all your reinforcements. Don't be. I think it probably depends on how your organization is run, but I think
Mhm.
in our region, in our state, people don't really call for medical control a lot for stuff like this.
Yeah.
Yeah.
It's okay to do that.
I think that it is poorly explained a lot of times a physician's power outside of a facility.
So.
Yeah, they can basically say, like, I cannot say that they are able to make that decision until they're seen by a physician,
Yep.
so they'll O1 them until they can evaluate them.
Mhm.
But yeah, physicians have the power to do that. And so if you can, again, contact them and articulate your case well,
Doctors
Because-
love when you ask for help.
Yeah.
They want to give you
they
advice.
want to do it. And make sure that you can talk to them. Because if you call and sound like a blabbering idiot,
They're going to be like, no,
going to make it much harder.
like, don't do anything that you think you should do.
They're like, you know what? Actually, no touchy.
If you are at all in a position where you have to be a voice for other people, you have to be a voice that can be heard. And that
Absolutely.
means you have to be articulate
you have
Yes.
to do
when
hard things.
advocating for patients.
Mm-hmm. Mm-hmm.
At the basis of all refusals, I know this is a tricky one. We made it like that on purpose, obviously. At the basis of all refusals, it comes down to effort spent educating the patient and making them explicitly aware of their situation and of your concerns, and documentation. That is what all refusals boil down to. So just make sure you are doing those two things adequately.
Absolutely.
And if you would like more information on that, the Standard of Care podcast has a great episode on documenting refusals. Highly recommend.
It's fantastic. Because we are in a day and age right now where the case that is going to take you to court, that you would be the most at risk for losing your license over, is going to be a refusal.
It is 100% true.
We all get very wrapped up in all of the other calls that we run, but this one is the sketchiest one that we do.
Mm-hmm.
All right.
Great
You guys
work.
Ready for some rapid fire?
Heck yeah.
All right, first one. We're going to do 10 what would you do moments. Just real quick. No full scenarios here. What would you do if your patient becomes apneic while you're stuck in an elevator with zero room to maneuver?
Getting
Like-
on that stretcher.
Only and it doesn't, it's one of those elevators where you can't lay them flat.
Oh, okay. I'm getting on the stretcher with the patient. I'm like straddling them.
Yeah.
And I am ventilating them while
Yeah.
they're sitting up.
I think
Just
that's
and
the
I get
best
to put
move.
the pressure of my body
Yeah.
to
Absolutely.
make a seal.
Yeah. Absolutely.
I thought that was a fun one.
That is a fun one.
And in the meantime, I'm going to see if my partner can maneuver themselves in some way to like hold their head in an appropriate position.
Because there's so many elevators like that. Like you can barely
Mhm.
fit in there with your partner, the stretcher,
Yeah.
and the patient.
Oh,
All right, what would you do if a family member keeps interrupting your assessment, insisting the patient always looks like this, while the vitals say, yikes?
I think that it depends how many people we have on scene. For me, I would hopefully try to get another. First, I would redirect. I would just be like, let me just try and talk to the patient, whatever, your nice little polite things that we do and say. And if it's still not, I would get my partner or maybe another responder on scene to go talk to them and be like, hey, can you help us out with getting X, Y, or Z? Give them a task.
yes. Super involved family members love a task. If you say, it is really, really important that you go find me this right now, they will be like, got it.
Yeah. I need every single med they've ever taken in their whole life.
Yes. I need every
Right
single
now.
supplement that exists in this home.
Stat.
All right. What would you do if your only IV blows during a hypotensive trauma transport and all extremities are impacted?
Cry.
Get an EJ.
Woo, woo, woo.
That's what I would say. I put this in here because recently I've encountered situations where an EJ was never attempted, and I'm unsure as to why. On the air medical side, receiving the patient, even from like facilities. Actually, the last one was from a facility, and it was interesting. And I found out at this facility they have to have an order to do an EJ, but still, try an EJ.
Try an EJ.
Yeah. And what if that doesn't work?
Drill them.
You can't. All of their extremities are affected.
Gone. Every single bone
It says.
just fell
I
off.
mean, if you have a fracture, you cannot put.
Yeah, everything's no
Oh,
IO.
that's risky business. Mm.
I think you just start hunting in weird places.
Yeah.
Subclavian,
Absolutely.
IVs.
Yeah. Try to get what
Look
you
at
can.
their chest.
Yeah. Like really try to get.
And then if
a
not,
nice
you may
forehead
need to
vein.
divert to a facility that is not a trauma center, and they might need to put in like a central line.
Yeah.
Absolutely.
It's
Man.
okay to divert.
Yes. If you have no access with a hypotensive trauma patient, you need to divert.
I would be stressed.
Guys,
Yeah.
I one time had to establish an IV on somebody that had no limbs.
See? It happens.
It does happen. This is
Mhm.
not made up.
Luckily, it was in a facility and I had an ultrasound machine, so like we got there. But
But see, that's why maybe you needed to divert.
Yeah.
Because even like a small ER would have access to something
Oh.
like that.
absolutely, if we would have been pre-hospital and they would have been very, very sick, we would have been up a creek.
Yeah.
Yeah.
All right. What would you do if both your O2 systems fail mid-respiratory call?
Call for help.
Oh yeah.
Like you've been running all day, so your portables are empty, and for some reason now your main is not working.
Oh, probably it's a leak.
Yeah, you'd have to call for intercept.
I'm getting intercept, another unit, a supervisor that can run me a tank, a co-responding agency that has oxygen.
I'm glad you called for intercept. I think that's don't
Mhm.
just try to like if they need oxygen, don't try to just like make it work. You know?
Don't blow in the nasal cannula or whatever your backup plan
Yeah, don't
is.
just try to-
21%.
Yeah, don't try to room air it the whole way. Yeah.
Yeah, I think that's another thing that we don't always do is call for intercept
Mhm.
if you're already ALS. But if something has failed in your equipment, either you need to weigh the options, right? Are we super close to the hospital, like we're about to turn in, or are we still like 10 miles out?
Absolutely. Is your closest unit farther away than your
Mhm.
closest facility?
Absolutely.
But like, weigh your options. Also, don't be afraid to have two options going simultaneously. So like if you have a supervisor coming to intercept you while you're still en route to the ED, you may be able to get closer in both directions.
Yeah.
So come up with multiple options.
100%.
FiO2. What would you do if your partner freezes on a critical patient and you need them to act now?
Expect that there could be a situation where you have to do it all by yourself.
Yeah.
They could die right now.
Absolutely. I also think that in those scenarios, be kind. Try
Mhm.
to be kind. Like I understand urgency. I'm not super great at this.
Yeah, and yelling at them is not gonna help.
Yeah, but instead of being like, get your shit together right now.
What
Instead
is
be
wrong
like,
with you?
yes. Instead be like, hey, like I need you here with me. And
Are
a
you-
lot of
are you
times
okay?
they can adjust and snap back in. But like so I've said, be prepared.
I mean, if your partner's driving, it would be the same scenario.
Mm-hmm.
What would you do if dispatch updates the call to possible active shooter scene after you've already made patient contact?
I would get on that
Welcome.
radio and say, "Hello, it is I. What is happening?"
Are
Yeah.
you? Is that for our scene?
Can I
Verify that
walk
it's for your
outside?
scene.
Unfortunately, that is not super far-fetched
No.
for us
Very much
because
not.
most of our calls come out unknown problem, and we're almost always there before it updates to a problem.
Yes.
Yeah, do you're the best to keep yourself safe. If you hear active shooter, then first of all, you need to assess whether or not that active shooter is your patient. And if hopefully it's not, get out of there.
Yeah. And I would say if you are dispatched to something that sounds violent and you have access to, please put on your vest. If you
Mhm.
have ballistic vests.
I was going to say, not your high vis.
Yes, your ballistic vests. The opposite.
The opposite.
That. But yeah, be prepared. I think there's plenty of times where maybe we haven't worn our vests, and it probably would have been prudent of us to do so. Rarely would we need it, if ever, in our whole careers, hopefully. But like when you need it, you need it, and this is exactly why you should wear it.
And don't be afraid to stage. Like, there are moments in our career where we basically...
The vibes are off.
Yes, where the vibes are off. And, like, there's moments where we weigh risk versus reward. Like, sometimes we choose to go in a potentially volatile scene because we think that the reward outweighs the risk. That's a choice, but don't be afraid to stage and wait for your scene to be secured by law enforcement, because a dead medic is not going to be helpful to a dying patient. So make sure that you keep yourself safe.
I think also it depends on the scene. Like if you need to there's a chance that at that point now we need to shelter in place. So that's also like bring everything that you would need on your calls, because you truly never know. Just like the stuck in the elevator situation.
Yeah.
Bring your bag in, guys.
Yep, and you may end up in a warm zone, not necessarily a hot zone, but that still puts you trapped.
A risk.
Yeah, for sure.
All right. What would you do if your patient suddenly loses pulses while you're carrying them down the stairs? This actually was somebody commented this, so I put it on here.
Well,
oh my gosh.
you got to get down the stairs.
You just keep moving them until there's a place where you can set them down.
Yep.
And then, because there's no really like 100% accurate way, I would say, to check somebody's pulse while they're correct.
Yes. So, like, option 1 is you go back up the stairs. Bad idea.
Weird idea.
Option 2 is you stop on the stairs.
Also weird.
Definitely not.
Bad idea. So only viable option is 3. Get to bottom of stairs, lay patient down, start CPR.
Nobody dies on the stairs.
Nobody dies on the stairs.
Nobody dies on the stairs. Yes. And depending on where you are, like, if that means that the first place that you can reasonably start CPR is on your stretcher or in your truck, like, you have to do it safely. That's fine. But a lot of times once we start a move, we don't like to stop a move.
It would be odd.
So we are like, oh, we're already carrying them. Let's just get to the truck. If you think that's the most appropriate thing for your patient, go ahead and do that.
Yeah, is your stretcher at the bottom of the stairs?
Yes. But don't be afraid to just like end up back in the floor in a
that's
different place. That's okay.
What would you do if you arrive and the patient only speaks a language none of you understand and the family is panicking?
Oh, story of our lives.
And what's the language? Call a friend.
Phone a friend. It depends. If you have access to a reliable or reasonably reliable translation device, use that. But also like use your eyeballs.
I think that just weigh the situation. Is this person literally dying and they're just panicking because they're panicking, but it's more confusing to you and scary to you because they're panicking in another language? Sometimes that just happens.
Absolutely.
They might just be panicking because their family member is dead.
Right.
So.
There's plenty of times that people panic in English and it's not helpful communication.
Right.
So
Correct.
Don't let a panic in another language
really make you panic.
Yes, make you feel like the situation's worse than it is.
Yes.
Use your eyeballs and assess your patient like you would assess any patient with or without a language barrier.
100%.
And then make a valid attempt to communicate with them. What would you do if the hospital diverts you mid-transport with a critical patient?
And I'm assuming they asked this because this happened to them.
Yes.
Yikes.
I think also this is very regionally dependent. Like in our region, we try our best to respect hospital diversion because clearly that means that they are running out of resources, right? But there are certain scenarios where that is just not possible.
If their resources are greater than mine in the time that I need them, then I have to come to you.
Yes,
right?
and I guarantee you they are because you're a hospital. So if you have a critical patient and they need a physician and this facility is on diversion, go there anyway.
Diversion is not a law. It is a request.
So don't compromise your patient's care because of a facility's diversion, but be responsible with diversion status. If they are critical capacity and they are running low on resources and you have another viable option, then
And take a little time out for yourself, right? Are you diverting? Are you wanting to go there because you're scared? Or because you don't have the capacity to take care of them? Because
Yeah.
chances are you are scared, but you do have the capacity to take
Mhm.
care of them. It's
I like
just going to
that.
be scary.
I like that.
And then this next one, we kind of went over it, which is why I brought it up there in the last scenario, is what would you do if the patient refuses transport, but their vitals are cuckoo bananas and they insist they feel fine? Which we kind of talked about this.
Every time you say cuckoo bananas, it makes me giggle.
It's a fun word.
Yeah, we did already talk about this, but have a conversation, a very honest conversation with the patient. And also, if it's something like this where the patient is like, I feel fine, try to get in contact with a family that's familiar with them and be like, this is what I'm seeing. Is this normal? Are their vitals always cuckoo bananas?
Where
and
are
if not,
you?
can you come over here and convince them to go to the hospital with me?
Yeah.
Right?
Yeah.
Yeah,
Pull
and
out some stops.
don't be afraid. And I think we've covered this a little bit, but don't be afraid to be very frank with your patient.
Yeah.
Mhm.
Be kind, but don't be afraid to use frank verbiage. You don't have to use like big medical terminology. You can say, "I'm concerned that I'm going to leave here and you're going to die."
That is
As a matter of fact,
reasonable.
don't
Mhm.
use extensive medical
Yeah,
terminology
stay away
when
from the
explaining
jargon.
this to patients because it means nothing to them.
Yeah, say things very frankly. Have family say things very frankly. I'm not above guilt tripping you with family members
No.
to save your life.
Definitely
Yeah.
not.
Well, that was a good one. Hope you guys enjoyed this. What would you do if? I think the biggest part is knowing when to own your decisions and when to ask for help. EMS has definitely taught me that judgment comes from owning your decisions, right? Like, that is, you might do something that people don't agree with, but if you are doing what's best for your patient, then own it.
Mm-hmm. You learn more from gray areas than you ever will from skills day.
100%. Because
Absolutely.
there's so many situations that you're like, what in the world is going on? Or you have to make weird decisions. And that, again, you just do what's best for the patient and own it.
There is no rule book for EMS. I know we have protocols, but those do not cover every
You couldn't.
weird scenario that we walk into. And Soph is right on the nose. If you make every decision with the patient's best interest in mind, you will be okay. Because at the end of the day, that is what matters.
And lastly, good judgment is staying calm when everything else isn't.
Yep.
If you are panicked, your decision making is going to be affected. So try to stay calm, wipe your feet on the metaphorical rug for a minute and take a breath to be able to make good choices.
Yeah. And ask yourself, am I scared? And if you are scared, it's okay. But just sometimes we got to slow down. And
Yeah, and
don't
there's-
make decisions because you're scared.
Yes, and there's some power to being like, oh, I am terrified, but I'm capable.
Yes,
Mhm.
you are capable.
Mhm.
You got here for a reason. So many of these we got from you guys, either in our comment section or some of you wrote in a time or two. But drop your real life, what would you do if situations in the listener tales. That's on our website. It's also going to be in our show notes, so you can follow the link there. We want to know all the gray areas you've encountered, and we want to talk about it. So we will see you next episode, and hopefully we will all be together again.
Yeah, and just remember, everything's going to be cuckoo bananas.
It is.